Assalamu alaikum students. Today we will continue our topic of cardiac failure. It is the second lecture on cardiac failure. So up to now we have discussed about what is the definition of cardiac failure, and then acute compensation, and then moderate fluid retention can be beneficial, then excessive fluid retention can be detrimental, and then compensated heart failure and decompensated heart failure. And this is the slide which we have left in the previous lecture. What is the treatment of decompensated heart failure? There is the administration of a cardiotonic drug such as digitalis, which increases the pumping action of the heart, so that more blood is supplied to the kidney, so that kidneys can function normally. And the second point is diuretic drugs, so that kidneys can excrete more fluid outside, and so that the fluid retention can be minimized. And the third is reducing water and salt intake, because we already want to excrete more water from the body because the heart is in failure state. So we have to reduce water intake and salt intake. As you know, the salt can retain water in the body. So these are the three treatments for decompensated heart failure. Now in the second lecture we will discuss about the unilateral left heart failure. The left-sided failure predominates over right-sided failure, and in rare instances the right side fails without significant failure of the left side. So normally there are more effects of left-sided heart failure, and when the left side of the heart fails without failure of the right side, blood continues to be pumped into the lungs normally and not pumped adequately out of the lungs by the left heart, because as you know that the right heart pumps blood into the lungs and the left heart pumps blood into the body, as the left heart receives blood from the lungs. So when the right heart is normal but the left heart is not normal, the blood cannot be received into the left heart from the lungs. So the blood comes from right heart into the lungs. So there is more pooling of blood in the lungs, and there is a pulmonary congestion or pulmonary edema will occur in the lungs. As a result, the pulmonary filling pressure rises because of shift of large volume of blood from the systemic circulation into the pulmonary circulation. So the mean systemic filling pressure in the lungs is raised. Thus fluid begins to filter out of the capillaries into the lungs interstitial spaces and alveoli, resulting in pulmonary edema, can cause death in 20 to 30 minutes in severe cases. So the pulmonary edema will result due to left side heart failure, but the right heart is normal in case. So edema in patients with cardiac failure, in contrast to pulmonary edema, left or right heart failure is very slow to cause peripheral edema. Three non-causes of reduced renal output of urine during cardiac failure, all of which are equally important but in different ways in retaining fluid. Number one is decreased glomerular filtration rate, reduced arterial pressure or intense sympathetic constriction of the efferent arterioles of the kidney. And second is activation of renin-angiotensin system and increased reabsorption of water and salt by the renal tubules due to reduced blood flow to the kidneys. And third is increased aldosterone secretions due to potassium ions. So these are the three effects which can retain fluid in the body when there is cardiac failure. So this is the link of heart with the kidney, how kidney can perform if there is cardiac failure. the functions of kidneys will be reduced. There is a reduced renal output of urine ultimately. And this causes, when there is reduced output of urine, this ultimately causes edema or fluid retention in the body. Atrial natriuretic factor delays onset of cardiac compensation. Atrial natriuretic factor is a hormone released by the atrial walls of the heart when they become stressed. And because heart failure almost always causes excess increase in both the right and left atrial pressure that stretch the atrial wall, the circulating levels of ENF in the blood increases 5-folds to 10-folds in severe heart failure. What will this ENF causes? The ENF in turn has a direct effect on the kidneys to increase greatly their excretion of salt and water, number one. And therefore, ENF plays a natural role to help prevent extreme congestive symptoms during cardiac failure. So, it increases the work output of kidneys. So when there is increased excretion of salt and water, there is less fluid retention, and when there is less fluid retention, it delays the cardiac decompensation. So the onset of cardiac compensation can be delayed by atrial natriuretic factor by increasing the excretion of salt and water by the kidneys. And from where it released? By the atrial walls of the heart when they become overstretched. Now it is a very important topic. Acute pulmonary edema in late stage heart failure. And it is a vicious cycle. How it is a vicious cycle? Firstly we study all the steps of all the 6 steps of this vicious cycle. Then we will see that how this vicious cycle works. Firstly, we are now studying about the story of acute pulmonary edema. Because of limited pumping capacity of the left heart, blood begins to dam up in the lungs. As you know, the left heart has become failed and doesn't receive the blood from the lungs, so the blood remains in the lungs. So there is pooling of blood in the lungs. The increased blood in the lungs elevates the pulmonary capillary pressure, and a small amount of fluid begins to transduce into the lung tissue and alveoli. When the blood is dammed or pooled in the lungs, the pulmonary capillary pressure increases, and due to this there is more movement of fluid from the pulmonary capillary lumen to the tissues, to the lung tissues. The increased fluid in the lungs diminishes the degree of oxygenation of the blood. So when there is more fluid, the oxygenation of blood decreases. The decreased oxygen in the blood further weakens the heart, and also weakens the arterioles everywhere in the body, thus causing peripheral vasodilation. So this decreased oxygen results in weakens the heart and causes peripheral vasodilation. 2 effects will occur due to decreased oxygenation. And why there is decreased oxygenation? Due to increased fluid retention in the lungs. The peripheral vasodilation increases venous return of blood from the peripheral circulation still more. So this peripheral vasodilation due to decreased oxygen in the blood results in more venous return, because the resistance to the blood to go to the heart decreases. So the venous return is increased. The increased venous return further increases the damming of blood in the lungs, because now the blood moves from inferior vena cava into the right heart and then into the lungs. So leading to still more transudation of fluid, more arterial oxygen desaturation, more venous return, and so forth. So the condition becomes more and more worse because there is more and more load on the lungs. There is more and more damming of blood in the lungs, and that's why there is more transudation of fluid, and there is more pulmonary edema. So the edema becomes worsen and worsen. The vicious cycle of acute pulmonary edema can proceed so rapidly that the death can occur in 20 minutes to 1 hour. Okay, so the story starts from the left heart failure and the damming of blood in the lungs, and at the last there is an increased venous return, but the blood doesn't go from lungs to the left heart because the left heart is failed. So the blood remains pooled in the lungs, and there is more pulmonary congestion. So how we can prevent or reverse this process? Heroic therapeutic steps. So we will take emergency therapeutic steps. First of all, putting tourniquets on both arms and legs to sequester much of blood in the veins, and therefore decrease the workload on the left side of the heart. Okay, so tourniquets are bind to the arm and legs, which tourniquet you can see in when you measure the blood pressure of a patient. The tourniquet is applied on the arm, or when when you take a blood sample, not blood pressure, sorry, when you take a blood sample from a vein in a patient. Firstly, you put a tourniquet on the arm so that the blood vessels become visible, so that the sample can be taken easily. So these tourniquets are applied on the arms and legs so that less blood goes into the heart, and that's why the workload on the heart is also decreased. And the other is bleeding the patient. Bleed the patient so that the blood volume in the body should be decreased, and giving a rapidly acting diuretic such as furosemide to cause rapid loss of fluid from the body, because as you know that there is pulmonary congestion, there is more and more fluid in the lungs, so we have to remove fluid from the body, and not only remove fluid from the body, and also inhibit or also reduce the flow of blood towards heart, because the heart is because the blood is going to add up in the lungs. So we have to reduce the blood which goes towards the lungs. We have to reduce the venous return. As you know, in the 6th point, the venous return is increased, so we have to reduce the venous return, so to decrease the workload on the heart, and giving the patient pure oxygen to breath to reverse the blood oxygen desaturation, the heart deteriorate, and the peripheral vasodilation. As you know, the deterioration of heart and peripheral vasodilation occurs due to a decrease in oxygen. You can see in the 4th point, the decreased oxygen weakens the heart and causes peripheral vasodilation. So oxygen is given to the patient, pure oxygen, and give the patient a strong acting cardiotonic drug such as digitalis to strengthen the heart, so that the left heart failure can be compensated. And when the left heart become work, so that the pooling or damming of blood in the lungs can be reduced. And now is the cardiac reserve. The maximum percentage that the cardiac output can increase above normal is called cardiac reserve. I have told you in the previous slides what is cardiac reserve, and in congestive heart failure it is reduced. So it is the maximum percentage that the cardiac output can increase above normal. So cardiac output normal is 5 to 6 liters, and above normal is cardiac reserve. In healthy young adults, the cardiac reserve is 300 to 400%. In athletes, trained persons, it is occasionally 500 to 600%. But in heart failure, there is no cardiac reserve. Any factor that prevents the heart from pumping blood satisfactorily will decrease the cardiac reserve. You can see here the cardiac reserve normal about 400, athletes 600%, and in disease states there is less than 400, 200 in moderate coronary disease and severe valvular heart diseases. You can see below 0. Diagnosis of a low cardiac reserve exercise test. When a person with low cardiac reserve remain in rest, he usually will not know that they have heart disease. A diagnosis of low cardiac reserve can be made by asking the person to exercise, which requires greatly increased cardiac output, and a small amount of reserve that is available is used up. So by exercise test, the diagnosis of low cardiac reserve can be made. The acute effects are as follow: extreme shortness of breath or dyspnea, and creating a sensation of air hunger, extreme muscle fatigue, and excessive increase in heart rate because the nervous reflexes to the heart overreact. So these are the 3 effects occur in a patient with the reduced cardiac reserve when he perform exercise. Okay, thanks.